Just make it full screen, Dr. Majumdar.
Yeah, I'll just do that. Thank you. So, good morning, everybody. Today, I've been given the opportunity to talk about this trial. And at the outset, although it is a negative trial, we will be dissecting a bit on how perhaps the authors could have improved it so that we could have had the advantage of some immunotherapy in a disease as aggressive as small cell cancer. So the evidence of obviously that we know SCLC is an immunogenic tumor, and we've had prior the atezolizumab IMpower as well as Caspian trial giving some evidence of anti-PD therapy as well as anti-CTLA4 therapy. The background for using this particular drug combination came from the Checkmate 032 trial, which looked at third-line population. And what is commendable that even in this cancer, when they used their 2-year OS rates was 17.9% in nivolumab and 16.9% in the combination arm. So that's what led then it came down to the second line setting where they looked at nivolumab versus chemotherapy. And although it was not a significant trial, we see that the median duration of response with nivolumab was 8.3% versus 4.5%. And this gave us a lot of scientific rationale to use chemotherapy, to use immunotherapy in the first line setting. So I'm coming to my study design, which was an open label multicentric trial conducted across USA, Europe, as well as Asia, predominantly China. So they looked at extensive disease SCLC with a good PS who had at least a stable disease or better after 3 to 4 cycles of platinum-based therapy. They were randomized in 1:1:1 ratio into 3 arms, where they received nivolumab 1 mg per kg plus ipilimumab of 3 mg per kg once 3 weekly, followed for 12 weeks, followed by nivolumab every 2 weeks, or nivolumab at a 240 mg flat dose every 2 weeks, or a placebo. And the primary endpoint they looked at was the OS with the combination arm compared to the placebo. They had multiple secondary endpoints, which looked at OS with nivolumab versus placebo, PFS of the entire arms in various permutations and combinations. But the most important I would pay attention to was the TMB status, because they did a pre-planned analysis for a tumor mutational burden, which was new and not included or mentioned in the previous immunotherapy trials. They were rather ambitious and they wanted a hazards of 0.72, which led to a 38% reduction in death. Coming to the results of the I'll just make one more mention, is that at the randomization was 9 weeks post completion of chemotherapy, which is quite a lot of time past the first cycle, past the last cycle of chemotherapy, and at least 11 weeks after radiation. Immunotherapy was started at least 3 weeks prior to the last cycle of chemotherapy. So remember that even though they were randomized up till 9 weeks, they made it as a pre-specified mandation that first dose of immunotherapy can be received only 3 weeks after the last dose of chemotherapy. And I feel that's quite substantial time for a patient to be without any systemic therapy. So coming to the results, this is the median demographic, which has been matched across all groups. So I won't go into that. I'll just go into the highlighted bits, which was that the complete responses was actually a lot more in the combination arm prior to randomization compared to the placebo arm. And also that you should see that the median range, that is time from last dose of chemotherapy to randomization, has been even as long as beyond 9 weeks in nearly 10% of the patients. And most of the patients had their first dose of immunotherapy beyond 5 weeks, which is like a month and a half without systemic therapy in a small cell lung cancer. The TMB mutation burden was evaluated in only 68% of the patients across the group, which I think is unfortunate because almost all patients should have had a TMB and as well as a CPS scoring analysis done at baseline. So so another thing that I would like to mention is that in the baseline characteristics, almost 40% of the patients had liver metastasis. This is significant because liver metastasis is a harbinger of poor prognosis. This has not been mentioned in the other trials, and it could indicate as to why these patients did worse compared to the other trials. Secondly, like I mentioned, mostly the 50% of them had beyond 5 weeks of therapy, and only 70% of them had TMB less evaluated, while only 50% or 40% or so had CPS scoring done at baseline. Median follow-up of the patient was around 8 months alone, but around 96% of the patients had follow-up of around a year, which is acceptable for a disease like small cell lung cancer in first line. Of note is that the dose of nivolumab received in the combination arm, only a median of 2 doses of nivolumab and 2 doses of ipilimumab could be given on time due to toxicity. And in the single dose of nivolumab arm, the median doses that were given were only 5. So these were substantially and significantly not exposed to adequate immunotherapy. Subsequently, the combination arm underwent immunotherapy in 2.2% across all groups, while any systemic therapy of note was given to only 30% of the combination arm, while 46.5% of the patients in the placebo arm went on to receive systemic therapy in the second line, which shows that maybe patients remain fitter if they were not given the combination arm and if they were given placebo or a rest between one line of systemic therapy to another. Coming to the efficacy analysis.
Swaratika, you have overshooted the time.
All right, sir. Yeah. Then I'll just I'll just run through my OS slides.
Okay, you can do that.
So the OS slides I'd like to mention is that this is your primary OS. Although they had a hazards of 0.72, their hazard ratio was 0.92. It crossed the interval, so therefore it wasn't. And even between the placebo, the 1-year OS rate was not significantly different. I'd just like to make a mention of my last discussion slide, that in an immunogenic tumor, why did this fail? Perhaps because because the treatment completion rates were grossly inadequate. There was no early exposure of nivolumab, which was seen in the Caspian as well as the Empower trial. And I feel the better patient selection, given the biomarker evaluation of patients should be better, and molecular subtyping of SCLC will lead to a better patient selection. Thank you.